Hello, my name is Dr. Farman Ali. I'm a GP, family physician. Today we will be talking about Gastro Oesophageal Reflux disease. This is commonly known as acid reflux. So what is Gastro Oesophageal Reflux, or commonly known as GORD? When the acid from the stomach leaks up into the gullet or the food pipe, the condition is called as acid reflux. This may cause heartburn and other symptoms. The cells in the lining of the stomach, they make acid for you, and they also secrete mucus which protects damage from the acid. There's a fine balance between the two. There is a circular band, also known as sphincter, at the bottom of your food pipe, which forms the junction between the food pipe, esophagus, and the stomach, and this acts like a wall, and it does not allow this acid to come back into the gullet. So, in short, acid reflux means that the acid leaks up or refluxes into the gullet. Oesophagitis means that there is inflammation in the lining of the gullet. Most cases of oesophagitis are due to the reflux of stomach acid, which irritates the lining of the esophagus. So what are the symptoms of GORD? Heartburns. This is the main symptoms. There's a burning feeling which arises from the upper tummy onto the lower chest. Pain is quite common in the upper abdomen and chest. It is described as a burning type pain, especially when you swallow hot drinks. Feeling sick, also known as nausea. Acid taste in the mouth, bloating, belching, and indigestion, also known as dyspepsia. These are like heartburns. They tend to come and go and tend to be worse after meals. Other mouth and throat symptoms such as gum problems, bad breath, sore throat, hoarseness, and a feeling of lump in the throat. Water brush, which is basically excessive salivation. Odynophagia, which is a painful swallowing due to severe oesophagitis may occur. However, this is a red flag sign and needs urgent further investigation. These were the common symptoms that we talked about. Now let's go to the atypical symptoms. The atypical symptoms of reflux will be chest pains. These are non-cardiac chest pain. They are not related to the heart. They are caused by GORD. 50% of the patients with chest pain and a normal coronary angiography have GORD. Usually there is no relationship to exercise, and this helps to differentiate between the acid reflux and chest pains related to heart disease or angina. Respiratory symptoms. These include chronic hoarseness, also known as Cherry-Donner syndrome, a chronic cough, and asthma-like symptoms such as wheezing and shortness of breath. Episodic or chronic aspiration can cause pneumonia, lung abscess, and interstitial pulmonary fibrosis. In 6 to 10% of the patients with chronic cough, GORD is the underlying cause. H. pylori infection, which is a bacteria or a bug that lives in the stomach and has been associated with stomach ulcers. This might be asymptomatic, and the association between this and acid reflux has been a matter of debate. However, there may be symptoms of peptic ulcer disease, for example, fullness, bloating, early satiety, and sometimes nausea. We come to the causes of GORD, or the factors that influence reflux. These include increased intra-abdominal pressure, inadequate cardiac sphincter, which is the valve at the lower end of the esophagus, smoking, alcohol, being overweight, and drinking too much coffee. Pregnancy, obesity, tight clothing, heavy big meals, surgery on the lower esophagus, also known as achalasia of the cardia, systemic sclerosis, hiatus hernia, certain medications such as tricyclic antidepressants, anticholinergics, nitrates, and heart medications including calcium channel blockers. So what investigations? Usually it is treated empirically in the absence of any red flag signs. An H. pylori stool test is performed. This is commonly done in general practice. However, as we discussed earlier, the association is a matter of debate. Endoscopy remains the gold standard. This is a thin, flexible telescope that is passed through the esophagus into the stomach. This allows the clinician to look inside, directly in the stomach. So what happens after the endoscopy? There are two terms that are used. One is oesophagitis, as we discussed, which is an inflammation of the lower end of the esophagus, or endoscopy negative reflux disease, in which there is typical symptoms but there are no changes noted on the endoscopy. A blood test is performed to exclude any significant anemia. As we mentioned earlier, although some of the chest pains may not be typical, it is important to rule them out by doing an ECG and a chest X-ray. Barium swallow may show hiatus hernia. It shows a fluid level on chest X-ray. Esophageal pH monitoring. This is a test in which acidity at the lower end of the esophagus is measured if the diagnosis is unclear. So what are the red flag signs? Patient may ask, can it be cancer? This has to be ruled out, especially if these are present. If there is dysphagia, which means a pain while swallowing, food sticking on swallowing at any age. If there is dyspepsia at any age associated with either weight loss, a proven anemia, or vomiting. If there is dyspepsia in anybody above the age of 55 or more with at least one of the following high risk features, which are onsets of dyspepsia was less than 1 year ago and he was completely symptoms free before that. If there is a continuous symptoms since the onset and not getting relief by common treatment. Other risk factors include if the dyspepsia is combined with either of the following risk factors. If somebody has a family history of upper GI cancers in a first degree relative, there has been a history of Barrett's esophagus, which is changes to the lower esophagus as a result of continuous exposure to acid. Pernicious anemia, dyspepsia associated with peptic ulcer surgery over 20 years ago. No dysplasia, atrophic gastritis, intestinal metaplasia. Patients who present with jaundice, or on examination if an upper abdominal mass is present. These are the red flag signs and the patient should be referred urgently to secondary care. Let's start with the treatments that the patient can do themselves. Stop smoking the chemicals from the cigarettes. Relax the circular band of the muscle, also known as the sphincter at the lower end of esophagus, hence making them more prone to have acid reflux. they have to stop smoking completely. Food and drinks. Common ones are peppermint, tomatoes, chocolate, spicy food, hot drinks, coffee and alcoholic drinks. Also, please advise the patient to avoid large volume meals. Review their medications. The most common culprits are anti-inflammatories such as ibuprofen or aspirin. Other medications such as diazepam, theophylline and calcium channel blockers, especially the nifedipine and nitrates, have also been implicated in causing acid reflux. Weight. If you are overweight, it puts extra pressure on the stomach and encourages acid reflux. Bedtime routine. So, advise the patient to go to bed with an empty, dry stomach, not to have anything at least in the last 3 hours before bedtime, and do not drink 2 hours before bedtime. Raise the head end of the bed by 10 to 20 centimeters. This helps the gravity takes over and reduces acid reflux. So what are the pharmacological treatments for Gastro Oesophageal reflux? Antacids. These are available over the counter, such as Gaviscon, Renes. These are alkaline liquids or tablets that can reduce the amount of acid, neutralizes the acid in other ways. A dose usually gives a quick relief. There are many brands and you can buy them over the counter from any pharmacy. Other medication that needs prescription, there are 2 types. They work in 2 different ways. First one is H2 blockers. H2 blockers are a group of medicines that can reduce the amount of acid produced in the cells in the lining of the stomach. They are also called histamine H2 antagonists, but commonly known as H2 blockers. Common ones are cimetidine, famotidine, nizatidine and ranitidine. These days they have been taken off the market because there was a scare about some contaminated batches. Proton pump inhibitors. Patients with reflux and no alarm symptoms, they should be given a full dose of proton pump inhibitors, also known as PPIs, for at least a month. They include the common ones: omeprazole, lansoprazole, pantoprazole, rabiprazole or esomeprazole. If the symptoms return after the treatment and long-term acid suppression is required, go for the lowest effective dose. This is to avoid any side effects from the medication. Remember, all your patients should have a treatment plan and should be told if they can stop if they are completely symptom-free. H. pylori infection. If proven by a stool test, it will require antibiotics treatment to eradicate the infection. The recommended treatments are either you give a 7-day course of proton pump inhibitor combined with amoxicillin and metronidazole. Both these antibiotics are given twice a day. For people who are allergic to penicillin, the proton pump inhibitor and metronidazole can be combined with clarithromycin. Again, the antibiotics are given twice a day for a full 7-day course. So when do you refer patients for endoscopy? It may be appropriate to refer some of the patients, those who have not responded to treatment, those who have new and emergent symptoms, patients with red flag signs that we discussed. These can be referred either via an urgent cancer treatment pathway or as an outpatient endoscopy. Patients who have been referred for endoscopy should be free from any proton pump inhibitor or H2 blockers for a minimum of 2 weeks. Advise the patient to rely on over-the-counter anti-acid such as Gaviscon or Redis for 2 weeks. So what happens after endoscopy? They might be diagnosed with esophagitis. This is when the esophagus is inflamed. If that is the case, please prescribe a full dose of PPI or proton pump inhibitors for a couple of months. Usually the patient will relapse and they may require long-term PPI treatment. Endoscopy negative reflux disease. This is a term when someone has typical symptoms of reflux but the endoscopy is normal and there is no evidence of any esophagitis. You treat these patients symptomatically and give them the lowest maintenance dose. Barrett's esophagus. This happens when the esophagus has been exposed to acid for a very long period of time, which causes certain changes in the lower end of esophagus. It is important that these patients are monitored and they may require repeat endoscopies in order to detect cancers or any abnormality early. If there is no abnormality found on the endoscopy, also consider the possibility of heart or biliary disease. Surgical treatment for GORD. Most patients with reflux symptoms are treated with lifestyle and medication and do not require operations. However, some cases which are resistant may require surgical operations. The surgical options, there are two. One is laparoscopic fundoplication. This has been advocated in the past, but recently evidence shows that the outcomes is not much different from long-term medical treatment. So during the fundoplication surgery, what they do is the upper curve of the stomach or the fundus is wrapped around the esophagus and sewn into place so that the lower portion of the esophagus passes through a small tunnel of the stomach muscle. This surgery strengthens the wall basically at the lower end of the esophagus, hence making it difficult for the acid to reflux into the gullet. Another treatment that has become popular is laparoscopic insertion of magnetic beads. This is done under general anesthetic. The implant consists of a ring of interlinked titanium beads basically, which keep the lower end of the esophagus closed by a weak magnetic force and only allows and opens during swallowing. Thank you very much.